So I'm just going to start by talking through the work that we've been doing in the north of England. At the end, I'll come back and talk through some of the practical things that we've done in Sheffield before we take some questions. So we were asked to do a piece of work which was funded by the Better Care Fund and done in conjunction with the LGA, and we were basically asked to look at 3 areas across the north of England, which you can see on the map over there. And each of those areas was picked for quite a clear reason. So there was Cumbria, which was a very kind of county council based area. There was Fylde Coast, which was a mixture of a county council and a unitary, and then there was Sheffield City, which was different again and feels quite different to some of the other areas in terms of the challenges it faces. And what did we do? So we did 2-week, what we would call assessments at each of those 3 different areas. And basically we spent time talking to leaders, talking to chief executive councils, and spending time with social workers and with nurses on the shop floor. And really understanding what the local context was for the delayed transfers of care, and really trying to understand what those common themes were across the 3 different areas. And we'll just talk through those now. So the first thing that was really apparent was that there's a lot of energy and time spent debating the numbers. And what's interesting when you compare different areas is the interpretation of what those numbers should be is slightly different, and I think that's an important point. And I think in terms of what we can do locally is those different interpretations can actually manifest themselves in the local authority having one view of what a delay is and a hospital having a different view. And the quicker you can get to that common language and that common understanding, the quicker you can focus on what's the most important thing, which is actually the people who are caring for. And I've sat in a number of A&E delivery boards where we spent 50-60% of the time debating, is it a delay or isn't it, rather than talking through what we're actually going to do to get this person home or to the best place for their care. What's really clear and not surprising is that everyone agrees on what is best, and what is best is typically home, and that's what we would want for anybody, what we'd want for ourselves, what we'd want for our loved ones, and that comes out loud and clear. The second thing which really jumped out for me, which again feels sensible and practical, but makes you wonder why it isn't always happening, is this concept of what's right for them, what's right for that person in that moment, not what's theoretically right. And people call that strength-based or based on their kind of local context. But that's really important, and again, that needs to permeate through everything that people do. So how does that come together in our kind of 3 key findings? So put the patient first, and everything else will follow. Again, it sounds simple, but then you wonder why it doesn't happen. And even just raising this conversation at breakfast, which I did with some trepidation with some friends from a different county council to Cumbria, we got straight into a difficult conversation around, well, that's really hard to do because of the local differences between health and social care and the number of CCGs. And I think all of us need to try and think of a way through that. The second thing is, let's use the data to drive where the real delays are, rather than just talking about it subjectively. And we'll come on to what we see as the biggest causes of delay in a moment, which has surprised a few people. And then finally, as leaders, and I think this is probably the most important thing for this group of people, as leaders, we have to set the benchmark for these people to make the right people-based decisions and the right patient-based decisions. And again, that can sometimes be harder than it needs to be. So the 3 main reasons for delay, so I roughly think of it this way. There's about 1/3 of delays which are actually caught up in hospital decision making, so waiting for something to happen in the hospital. there's about another third of delays waiting for some kind of community-based event. Now that sometimes can be a local authority activity, which might be residential care, but quite often is about community care from community hospitals, and increasingly getting the flow working across those two areas of the system is critical for reducing delays. And then around 23% of delays, which you would refer to as the kind of the more traditional or the kind of publicly held up reasons for social care delay, so waiting for some kind of care at home. And I think it was that last number which surprised people. I think the perceived wisdom was that was going to be a lot higher, but that's what the data told us from our studies. So there's a little bit of detail on the next two slides, and these slides will go out, so I'm not going to talk through the detail. The key thing on this slide for me is it feels like it's a home care problem, but actually the start of this conversation to get flow working in this area is more about reablement, and that takes you also into the conversation about integration between rehabilitation and reablement, and takes you right into the accountable care conversation. And I think there's a real opportunity at the moment in the joint health and care system to tackle some of these things, and I think that is one example. The next example, which is from Sheffield, is again quite similar in that need for joint working. So the key thing for me here is that the lack of appetite to take risks in the hospital. And when you dig underneath that, that's because they don't really understand what the council's actually doing in enough detail to trust it. So you can only build trust by, making those teams work, as joint teams and sharing in joint success and sharing joint responsibility, as we know. So those are the findings. I'll come back at the end and talk about some of the other things we've been doing, and I'll hand to Rosie.
Thanks. So I'm just going to set a little bit of the government context, but I've lost my... Oh, it's come back up. Obviously the Better Care Fund itself is not purely about delayed transfers of care. We do have a need to remind people about that at the moment. And really we're part of and the sole national programme that the government has in terms of taking forward its approach to integrating health and social care, which, similar to the message from Matt, is about the person and the people and putting services and systems and care around them. So that is the sort of overall context for the Better Care Fund itself. But obviously, in terms of the last few months, the budget in spring brought about an injection of money, which everyone was very welcoming of. I have to say, I've never known £2 billion to cause quite so many arguments as we seem to have managed to bring about, but we have. But that funding is there. It is alongside the Better Care Fund itself and the additional precept raising powers. As part of that, there was a condition of the grant that systems needed to implement the high impact change model, which tied into what was being required through the Better Care Fund. So why the focus on transfers of care? Clearly, it is a very hot political issue at the moment, but that is because of people underneath. And it is because, whatever the arguments over anything else, staying in hospital for longer costs individuals and people their health and their well-being. So it's not that this isn't the right focus to have. Delays have been going up, and they had been going up at a pretty alarming rate, which all in all was undermining your attempts to help the health and well-being of your residents. So in terms of the focus within the Better Care Fund and through the IBCF, it was about the high impact change model. It was about building on the very strong work that had already gone out across systems, joint working from the LGA, from NHSI, NHSE, ADAS and others, to really think about what are the things you need to have in place to ensure good flow, to ensure that people get home, that you can assess them once they're home rather than in hospital. All of those things that sort of everybody understands are right, but it's about giving the impetus for implementation. They also represent a really good way of showing how integrated your systems are, how well you're working together across different aspects of your systems. So yes, we did the very popular detox trajectory exercise through the BCF. We, through that, required everybody to set metrics for reducing delayed transfers of care, and we asked you all to resubmit those, and as part of Better Care Fund approvals and assurance, we've got through almost everybody's. There are trajectories in place for almost everybody at the moment for delivery by the end of this month. So firstly, I would just say we acknowledge that this was a process done under a lot of pressure, with very short timescales, with a methodology that was not deliberately designed to be confusing, but was confusing, and that we appreciate all of the effort that went into coming back to us with those trajectories. We appreciate the effort that everybody put into that, and we are very grateful to everybody for working with us to get things in place in time for winter. We are thinking through what worked well, not very much of that bit, but what we can do better for the future, and we're very open to people coming back to us. We aren't yet clear whether there will be another one for next year. I probably would bet there might be. And so we are very keen to understand how we could do it better, and we would probably start with a clearer methodology in the first place. And ideally, I'd like to be out to councils in the new year so that we can have the trajectory set before the year in which it relates. So, but that is, I'm afraid, outside of my control. But thank you to everybody for joining in with all of that entailed, and I shall pass over to Ian.
Thanks very much, Rosie. You bet there might be another one.
I would.
Go on. So
I would bet there will be another one.
Okay.
I went too civil servant for you.
Oh, right, okay. Wow. I've got 5 points I just want to share, just 5 little thoughts. That first and foremost, as both Matt and Rosie have said, it's not about the money. It's not all about the money. It's about quality of life, and there's plenty of evidence that hospitals are not a healthy place to stay in any longer than is absolutely necessary. And we heard from Philip this morning that NHS in England, which is a national religion, I think, is, 17th, did you say, out of 23rd internationally, and is only goes up the league table because of the accessibility and because it's open for deaths by non-communicable disease. So we need to keep people out of hospital as much as possible. And I think that we in this audience, particularly through our public health activities, are doing all that we can to reduce that particular flow. But yet again, the second point is that having said it's not all about the money, guess what? It is about the money. We all remember that lovely quote from Izzy over there back in August, who talked about unrealistic and unachievable targets for councils to cut bed blocking. It was counterproductive. And I think we'd all agree with that. And the threat of reviewing councils' funding allocations for social care could leave many councils facing the absurd situation of failing to meet an unobtainable target, losing their funding, and on top of this, potentially being fined by hospitals. So it is about the funding. And I'm sure that some in this room share the naughty step with Cumbria, even though apparently we've not got a joint letter from Sarge and from Jeremy. That must have been lost in the post somewhere. So the third point is there's always a choice. There's always a choice. But sometimes that choice isn't being made by the right person and perhaps not at the right time. Matt, when they did their work in Cumbria, and actually they only did in the north half of Cumbria because we've got 2 CCGs, and so that makes it even more complicated. And the CCG in the south, it's Cumbria and Lancashire. And I think that there are some in the room who know that Lancashire aren't in a particularly good state at the moment. So it's choice. And when Matt looked at a particular lady called Mrs. A, who went into hospital on the 21st of April. She was diagnosed as being medically fit for discharge on the 25th of April, and it was the 26th of June before we were able to get her out. And one of the reasons was that she was given an offer for help at home that wasn't acceptable to her. And from then on, she got a little bit confused. And some of us might have said that the clock needed to start again as to whether she was then fit for discharge when she got confused. And so whether it was all local government's fault, there's that word, I'm not so sure. But we need to make sure, and we need to have the conversation early enough in the process to identify what needs to happen to help people get back to home and out of hospital as soon as possible. So having said that there's always a choice, well, actually, we really don't have any choice, do we? We have to do this. This has to be done for no other reason that it's for the benefit of our residents. And we've got a problem that's got to get sorted. Government can't do it. NHS can't do it. No one can do it on their own. We need to collaborate. We need to work in partnership. We're all good at that. In this room, that's what we do. We need to understand that partnership's difficult, but we know that, don't we? And we've got to work towards a win-win situation. And yet again, there needs to be local solutions and locally created by partners. We really don't need top-down determination. And I think that for many of us, that's one of the big problems that we've got with our NHS colleagues. Fifth point is that, well, not all the politicians around are elected members. I think that we're all quite aware of, sat around the table, elected members who are politicians, and all the rest of the people around the table are playing politics of their own. Not party politics, perhaps, but politics nonetheless. So the final thought for now is that the most important work that's been said in the last few minutes is about collaboration. Different sectors, different structures, different cultures, different pay levels, different ways of working, but the same goal: to improve a service, to improve the experience and lives of residents who need our help and care. So, I've gained some time, folks. I've gained some time. That okay? You want anything to come back? Yeah, you're desperate to come back. Come on.
So there's just, picking on that point of collaboration, there's probably just 3 examples from Sheffield which are worth bringing you just in terms of what we've done to show some practical example of that collaboration, which I think is helpful to share. So I'm just going to click through because I don't want to lose your time. So the collaboration was all focused around getting control. And we focus on 3 things: getting control around the data, putting in place a set of shared meetings and working practices where we had people from the local authority there, the mental health trust, as well as the hospital and the community provider, all working on the same thing in the same way and working with people. So we started by agreeing a set of definitions, a set of definitions that everyone got behind and believed in, and they weren't prescribed by one particular organisation. And the act of actually just collaborating to produce those in of itself started to create a joint mindset which we hadn't seen before. We put in place some existing changes to existing meetings and some new meetings, which went right the way through to a shared chief exec meeting with the chief exec of the hospital, the CCG, and the council in the same room talking about delayed transfers of care when it was at the level that they needed to look at it. And that word collaboration and that collaboration that they were showing went right the way through to the front line, and that was fundamental in some of the change that we've seen. And then the last thing we did was a number of things around what you would sort of glibly call creating space. So we've created forums where, again, cross-system, people come together to actually sometimes have it out and have a row about what's gone wrong and what's worked well in a really safe and controlled way. And for me, the most telling thing about all of that, and I think it links to your point around collaboration and what I would call mindset, is at the last one of those events, the chief exec of the council, so John Mothersole, took me to one side and said, I can't really tell which organisation people work for anymore. It feels like one organisation. And then later that same day, Maddie Ruff, who's the accountable officer of the CCG, took me to one side and said the exact same thing. And they'd not been in the room together. And for me, that's what we should be aiming to achieve. And I think that helps with this, but helps with a whole bunch of other things too.
Okay. Has it made any difference to Sheffield?
Yeah, so you team up nice for my chart.
Next slide, okay,
yeah.
Fine.
So if you look at the improvement in delays and to try and account for some of that noise, and we're obviously very data nerdy people. Last year August to September improved by about 5% because it always does, but this year it's improved by about 25%. And sure, that isn't just down to what we've done. There's lots of other things happening, but I think that mindset is critical to that.
Okay. So what would you wish more could be done in Sheffield? What have they not done that you wanted them to do in Sheffield? What was a barrier?
So I think Sheffield's got to the point now where it's got rid of a lot of the let's call it the basic delays, and now there are some more complex things coming. For example, how they commission their capacity to do CHC assessments is now actually an issue they've got to wrestle with, whereas a month ago it was how do we use the capacity to do CHC assessments. So I think we're at an interesting point now where there are some real decisions and actions to be taken rather than just working at best speed, if that makes sense.
Okay. I'm going to go to questions next, and I'm seeing Izzy's hand up there. I've quoted her already, but just beforehand, I think that CHC assessments are going to be one of the next big things about the pushback from local government to our NHS colleagues about some of the spend that's going ahead. Right, I've got about 4 or 5 hands up there. Clearly, I'll start with Izzy because you do such a good job as chair of the LGA's board.
The issues that we've got on DTOC, which have happened over the last few months, are really coming around to address short-term winter pressures. Now, everything that we do in local government is about reducing demand, trying to keep people out of the front door in hospitals, and bearing in mind that from 2010 to 2020, 16 billion has been reduced from local government budgets. At the same time, 8 billion increase in the health service has happened, and yet we've bent the curve of demand. So where in all of this do we think that target setting and monitoring is actually going to benefit the communities that we're trying to future-proof, not short-term winter pressures, but future-proof to have a system that works into the next decade and beyond?
Shall I?
Please.
I think there is still a wish in government to think through the long term and to go further with trying to be more long term about a lot of the pressures. But as we all know, getting through winter without the media focusing every day on something like ambulance delays and patients being on beds in corridors, is also something that they absolutely have to sort. And so I think the only thing that we can do at this point is try and do all that we can, targets aside, around improving the experience for people in hospitals and keeping them out in the first place, and when they're in, getting them out as quickly as is possible, to give ourselves the space to resume the conversation about the longer term, and to resume the conversation through the Green Paper, which it's been announced will come out in the summer next year, and to try and create the space so that can be the thing that is most focused on, and to keep winter under control next year would give that space for this will keep being something that is beyond just targets and detox. But at the moment, I don't think the government is in a place where it is thinking that through. It wants to manage winter this winter, and then I think it will be about trying to make sure the conversation gets back on track, focuses again on long-term integration around person-centred care.
Okay, right. Well, loads of hands up. Next one's Philip. Gentleman at the back next. Then the lady in the second row. Then Paul Carter. Then the lady with a hand waving vigorously, second row from the back. So, Philip first. Then you, sir, at the back.
Yeah. Thank you, Philip Blond from Res Publica. I noted, Matt, in that very interesting slide you put up of reasons for delayed transferring care, roughly just over 50% of it was put down to, care after hospital, whether care with enhanced training or not. And the problem, it seems to me, will never be solved unless we can solve that. But we can't solve that because the money goes into the NHS and then doesn't go into the residential care sector. Now, part, I think, of the problem earlier is we have an NHS where we're sending all the money into the emergency acute centres, which are incredibly difficult to decommission, and we find it incredibly difficult, again, to get the money out from there. We in Res Publica, back in 2016, proposed a ring fence around the costs of keeping patients in hospital, which we then calculated up to 2021 was about 3.3 billion. And set against, if they were in residential care, 830 million, because roughly speaking, a residential care bed is about a third the cost of an acute bed. And we argued that the difference, about 2.4 billion, should be ring-fenced to actually start to endow the residential care sector such that it could take people from hospital quickly, and that we had the capacity to take people from hospital quickly. And that then would induce the type of space that we need to get hospitals working. But none of the reforms we're talking about seem to be operating at that level of policy. They're all internal within NHS, without seeming to speak to the policy environment outside that really is quite determinative.
I think it's a yes.
Very interesting, yeah. The other thing I would add to what you said, all sounds very interesting. I can't really talk about the national policy position. Is there is a lot of what I would call opportunity to get flow moving in the system before you even think to some of those really big things that you're talking about. So I would sort of defer those questions to probably politicians rather than me, but what I wouldn't underestimate is how much value there is in just getting flow moving right now.
Absolutely.
I'm not countering. I'll just come back quickly. Yeah, that's about 50% by your own figures. But surely counties, again, we need to stick our heads over the parapet, speak as if I'm a county, and start to decommission some of the central health funding to equip the architecture around hospitals. Because otherwise, it's limited what you can do in terms.
I think that's a conversation and a discussion to be had outside of here. And I'm quite certain that there are many people in the audience here who'd want to engage with you to see how that could progress. So I've got a gentleman halfway at the back there. Yes, sir.
Yeah,
Who are you?
I'm sorry, I'm from Cornwall. I'm a Cornwall councillor, Cornelius Olivier. I asked a question in the earlier session, but one of the key problems, perhaps the key problem, is that standards of pay, employment conditions and levels of training in the social care sector and residential care are very low. So what is the best way to raise those very low standards in social care of employment, wages and training up to the levels of the National Health Service? I mean, the gentleman, Mr. Blogg, just mentioned how much cheaper residential care was than hospital care. Well, residential care is too cheap. We don't spend enough money on it.
Okay. Right. Rosie, you're going to answer that one.
So I think clearly throughout the journey of integration of health and care, workforce and a lack of parity have been big issues in terms of this, and, you know, issues of nursing homes, losing nurses to hospitals and so on. I think the key best practice that we're seeing from around the country are where workforce strategies are being developed across the health and care system at the right geography for your area, trying to tackle some of those, trying to improve the pathways between, so that it's not all just a one-way street, and there are pathways back to the residential nursing and care home and home care sectors. So I think it is about trying to sort of operate those workforce strategies locally and sometimes regionally, and about government thinking that through in terms of the Green Paper for coming up in the summer. Okay,
but some of the challenges are the different terms and conditions that the two sectors operate, as well as the levels of pay. Because I'm sure that Cymru is not alone in when we had public health come back to local government, we were able to take out shed loads of money at that time. Lady in the front.
I'm very pleased to say that even though the September figures were the last ones that came in, our current figures are significantly lower, and a lot of that was to do with inaccurate data. And the data has been cleansed, and it was only cleansed because our chief exec of adults said, I want to sign it off every week, and that actually put it right. But the point I want to make to you really is that we are working well with our health partners, and currently we are jointly commissioning beds. We were paying 500 a week, NHS was paying 1,000 a week, and they were significantly affecting the price of beds within the county. They're letting us do it at the moment, and no, I'm saying they're letting us do it at the moment. We're very conscious that when things get really difficult during the next few months, they will revert back and go out and panic buy beds and pay whatever, and that then affects not only health budgets, it affects ours as well. Now, we really want to work jointly with the CCGs so that we do share budgets and that we have one person over those shared budgets, but we are meeting resistance from the finance director in the CCG, and we really need somebody from the centre to give a clear instruction to say you must share to reduce costs not only for our side but for the health service as well. There's so much more that could be achieved by an extra push from the centre.
Absolutely. Go back to you.
If I'm honest, I'm not sure you'll get that steered before this winter. Some of the so you know, I think we need to move towards that, and I working in the sort of integrated end of this would say that. I'm a DCLG civil servant working in the NHS across a joint team. What we're trying to do is make sure that those messages are clearly being communicated and being heard, but it's not something that I think is necessarily going to land this winter.
Okay, I think, Heather, it might be something that Izzy can take forward on behalf of all of us. I see that there's a gentleman at the back there with a microphone. We might have heard from him at some stage in the past. I think it's Paul, isn't it?
As much as the BCF additional funding is welcome, the fundamental underlying problem is there's been a diminishing amount of proportion of the National Health Service budget going into primary care and community care. Rob Whiteman gave me the figure last week that it's the primary care budget, with a bit of community health services wrapped around it, is now only 7% of the totality of the National Health Service budget. Coupled to the fact that we've got diminished investment in social care services, is a car crash of enormous proportions. Even in our STP land in Kent, we've now at last got health officials to work out that for every additional £1 million spent on primary care and community health, you will save a 4 to 5 times multiple in acute hospital budgets. The fundamental problem is that we need to get that money out of hospitals into primary and community care, and quickly, because the home is best policy is absolutely right for geriatrics with multiple conditions. And somehow or other, the STP, the transformation element, was supposed to be funded, and there was going to be big money flowing into invest to save money in primary and community care. But of course, that transformation fund got blown by the overspending of all the acute hospital trusts. And there is no new money coming in to really lead change and transformation in delivering good local care in all its forms. And until the National Health Service and government wake up to that reality, it'll be a very slow burn of transformation.
Okay, thank you for that, Paul. I've got a lady second row from the back, and then I've got a gentleman over there, a gentleman there, and then I'm going to close it, folks.
Thank you. When you were looking at the delayed transfers to Sheffield, I wonder whether or not you actually broke it down, because I'd be interested to know what the figures were like for people who have a mental health condition, older people who are held in hospitals because there's nowhere for them to go, particularly people who are on section orders, and you can't lift the section order because there isn't anywhere for them to then head off to.
If you grab me afterwards, I can get that data for you. That's fine.
Okay. Yes, sir.
James Jamson, Central Beds. The simple question that follows on Paul's, when are you going to bite the bullet and take money out of the acute sector and give it to the rest, as opposed to what you're doing, which is the opposite at the moment?
Good question, but I'm afraid that Rosie's...
Not one I can answer.
Not one she can answer. Final one, my friend from Hampshire.
Keith Manns, Deputy Leader of Hampshire County Council. I happen to disagree with Rosie Seymour. This is the time to strike. Not wait until the spring when the caravan will move on and start discussing other things. The fact is the health service, and I speak as someone that was PPS to the Secretary of State 25 years ago, when we were talking about a primary-led health service, and as Paul and Izzy has rightly said, it's gone in the opposite direction. The bed blocking is entirely the result of the health service spending the vast majority of its money on acute hospitals. And it's not up to us now to bail them out. This is the time to strike, to indicate to them if they want to get through the winter, they need to give us more money.
Okay, thank you for that. I think, again, that's not answerable from yourself. Can I ask you to thank both Matt and Rosie in the usual way? And it's not as something that will end here.